Hey everyone, and welcome to Chef AJ and Friends. Today we have from Moving Medicine Forward, Dr. Michael Klaper and Dr. Zach Burns, and they're going to be talking about the conventional approach to diabetes and why it's not working for most people. Please welcome them to the show. Hello, gentlemen. How are you today?
Doing well. Great to be here.
Lovely to be
Great.
along. Absolutely. Good to be with you.
Almost there could be a theme why the conventional approach to everything in medicine isn't working. We could just take one disease a month because the conventional approach doesn't get to the root cause.
Indeed.
I
Indeed.
think particularly with diabetes, we're seeing the consequences of a conventional approach that's failed us. Diabetes is still on the rise. I wanted to open with a little epidemiology, basically painting the big picture of diabetes. And I won't burden everyone with too many statistics, but it's something that I think illustrates the problem is that while about 11.5% of Americans have diabetes, it accounts for 1 in 4 healthcare dollars. So $413 billion every year. And that's 1 in 4 of our total health expenditures. So it's very expensive. It's only getting worse. So today we're going to illustrate, kind of show you, because we've seen it, we've trained conventionally. We're going to show you what kind of happens when someone's diagnosed with diabetes, and of course, how we can do a little better.
Well, I'm looking forward to that. I have a lot of people in my life that have it, both friends and family. And you're right, the conventional approach is not working.
So we have a case. Dr. Klaper, do you want to introduce our fictional patient, Terry?
Yes, Terry is, I think, just a classic representation. She is let's see, is a 47-year-old female. She's got a history of high cholesterol and pre-diabetes. She was walking around with A1Cs of 6.2, which this means that 6.2% of her hemoglobin is sticky with sugar. That puts her right on the pre-diabetes cusp. For quite a come though she's run into some problems with that as she shows up for her annual physical. For the past few years, her lipids have come down to normal on a moderate. She's on a statin, and so that's cranked down her lipids. She's a manager at a casual Italian restaurant, and she consumes about 8 cocktails a week. So she works at an Italian restaurant. She's the manager. She doesn't smoke. Got a family history. Her mom or dad had high cholesterol, diabetes, and Alzheimer's disease. She reports doing well today, but on a review of symptoms, she does report increased thirst. Her physical exam, her heart rate's a little elevated at 90. Her blood pressure is 138/90, a little bit up. And her body mass index of 28 puts her a bit on the overweight side.
Oh boy, Dr. Klaper is freezing on my end. I don't know if he's...
Oh,
Still there for me.
okay. Neurologically, she's intact, and physical exam is normal, but when the hemoglobin A1C came back, it came back at 7.5% of her hemoglobin is sticky with sugar. That puts her into the frank diabetes range, and that's of concern. Her lipids came back moderately elevated, but she's on a statin. So here she is sitting in front of her doctor with a clearly elevated blood sugar and diabetic range. Let's tune into the conversation between Terry and her physician.
Okay, so Chef AJ, would you do us the honor of playing the fictional patient, Terry?
I am. My mouse, I'm having trouble with my mouse to get the script on. What is the technology? Yes, I can actually do it. Once I can pull this up, it's like my mouse. Charles, my mouse is not clicking on anything. Hold on, let's open it.
We're going to have this encounter, everyone, this sort of mock clinical encounter, but it represents really what happens most of the time when there's a new diagnosis of type 2 diabetes. And it's usually in a primary care setting. And this isn't to denigrate primary care or our colleagues. Dr. Klaper and I do primary care. We've devoted our careers to it. We think that we as a profession can do better. So this serves to expose some of the issues with new diabetes diagnosis and how we can repair our approach.
Great.
How's it looking, Chef AJ? Can you see your screenplay?
I'm trying. Well, let's see which one it is. Let's try again. Is it this hard in show business? Okay, got it. Okay, here we are.
All right, whenever you're ready.
Okay. So how are my numbers, doctor?
Well, not terrible, but Terry, your sugar's in the diabetic range.
You mean I have diabetes?
Technically, yes.
Oh man, but my sugar was okay last year. How the heck did this happen?
Well, it's been creeping up over the last few years. I know you have a family history, so there's probably some genetics at play. Has your diet changed?
Well, it's probably the same as last year, but since you found my high cholesterol a few years ago, I've been eating more chicken and fish.
Oh, good for you. Terry, diabetes is something we really need to control to prevent complications down the road. So I'd like to start you on a medicine called metformin.
Well, what are the side effects?
Metformin is very commonly prescribed and generally well tolerated. Some people do have some GI upset, like diarrhea.
Oh, doc, I'm already prone to diarrhea. Is anything else we can try?
Well, there's a newer class of meds that you're now eligible for because of that A1C level, your average sugar above 7%. Have you heard of Ozempic?
Well, with all due respect, doc, I mean, who hasn't heard of Ozempic? Will it help me lose weight?
Yeah, it typically facilitates weight loss and also lowers blood sugar. There can also be GI upset, but less diarrhea, more bloating or nausea. If you have those symptoms, they often go away in time.
Well, are there any other side effects?
Rarely, it can affect the pancreas or the thyroid gland. You've never had pancreatitis, right?
Yeah, I never had it.
And there's not thyroid cancer in your immediate family?
No, nobody.
What do you think, Terry?
Well, I mean, if you feel it's necessary, doctor, I'll try the Ozempic.
It should help you eat less, lose weight, get that A1C below 7. Try to watch the carbs in fast food.
Oh, my fast food is minimal these days, but I'll certainly watch the carbs now that I have diabetes.
Let's follow up in 6 weeks, Terry.
One more question, doctor. Is diabetes permanent?
It can be managed really well. We'll get it under control.
So it's like my cholesterol? I mean, is that how it works? Well, okay. Well, thanks. I'll see you next visit.
Nice to see you. My team will confirm insurance coverage, and then the Ozempic should be at the pharmacy. Any questions, just let us know.
Thank you. Well, okay.
All right, so cut. So
I
we're
just want
back.
people to know this is a reenactment, because can you imagine they just go to the YouTube and I'm saying I'm eating more chicken and fish, and this was
Right.
a reenactment.
I know, and that I'm presiding over this important case like this. So no, this was a mock encounter, and we're going to talk about some issues with it. So Dr. Klaper, what just happened here?
What just happened is the all too common encounter with a patient with newly diagnosed diabetes. A couple of terms went by that really clanked in my head as far as is diabetes permanent? Well, we can control it. Okay, not a wisp of hint that this is actually a reversible disease. The true cause of it was never really gotten to. All that was planned out here was similar to, as Terry rightfully mentioned, is like my cholesterol, which is being pounded down with statin drugs. Here we are pounding down her blood sugar with Ozempic, but it doesn't get to the true cause. Why is that blood sugar up? Excuse me. Is it just a matter of bad genetics? No, there's a lot more involved in that. So let's talk about the real cause of type 2 diabetes and insulin resistance here. Let me take a moment to show some slides.
And while you're doing that, if I were to play the devil's advocate, this encounter was not technically inappropriate. And that's the problem. This is the standard of care. the only thing that was technically wrong was, and this is, for people interested in the details here, you got to do a retinal exam before starting one of these GLP-1 drugs like Ozempic to make sure there's no retinopathy. And you should screen for symptoms of gastroparesis, where the food isn't moving through the tube adequately, because that can get much worse on this class of drugs, GLP-1 receptor agonists. Other than that, the encounter was technically appropriate, but it's just like there's so much wrong with it when you dissect deeper. So what is the pathophysiology of type 2 diabetes, Doc?
Sure, thank you. And thank you, Dr. Burns, for being a conscientious physician who certainly did bring in those very important clinical issues regarding retinal exam and the questions about gastroparesis. Those are important issues when it comes to people with newly diagnosed diabetes and these GLP-1 drugs being considered. Let's talk about what's really going on here. I'm going to show these slides here, and it starts out with a very important concept: disease reversal, because type 2 diabetes is eminently reversible. And this was shown way back in 1927 by a professor at Yale, Dr. Sweeney, who took two groups of medical students. These are healthy young men back in the 1920s in medical schools, and healthy young guys, and put half of them on a diet high in carbohydrates to the nines for 2 days. These young men ate nothing but sugar, candy, pastries, white bread, baked potatoes, syrup, bananas, rice, and oatmeal. This is a high carb diet. And after 48 hours of that, they were given the classic glucose tolerance test. And that means they were given a drink with 100 grams of glucose. Their sugar goes up, goes down with normal pancreas function. And 2 hours later, their blood sugar should be well below 110, around in the 100 range or lower. And indeed, if you can look here where my arrow is moving, all these young men were well back into the normal range. All that sugar did not impair their ability to handle sugars. They all had a normal level after 2 hours of eating that glucose load. But half the men he put on a high-fat diet. For 48 hours, these young men ate nothing but olive oil, butter, mayonnaise made with egg yolk and 20% cream. 48 hours of that, and he had them drink that glucose drink, and 2 hours later, every one of these young men had blood sugars in the diabetic range. Well over 140 and some well into over 200. Now, the good news is after they resumed their normal diet, this all reverted back to normal again. This is reversible, and even Dr. Sweeney showed us that in 1927. But the difference when people talk about diabetes, and as Terry in our example says, you got to watch those carbs, watch those carbs. The carbohydrates are not the problem. The elevated carbohydrates are the tail of the dog. They're the result of clogging up these insulin receptors with fat, not the cause of it. So let me just show you some simplified diagrams of how it works. Here's a muscle cell. It burns sugar, glucose for energy. Person eats an apple. All this glucose shows up in the bloodstream. You got to move the sugar in from the blood into the cells. And to do that, the pancreas puts out this protein called insulin. It engages the insulin receptors that send signals through the cell to say, let that glucose in. The sugar is entered and burned. This is how it's supposed to work. But if the person's eating a high-fat diet, as most Americans do, bacon and eggs for breakfast, cheeseburgers for lunch, chicken for dinner, ice cream for dessert, they're keeping fat in their blood all day. And as a result, they're walking around with blood full of fat. And as the months go by and then the years go by, that fat oozes into the muscle cells, and it accumulates, a big word here, intramyocellular lipid. Intra means inside. Myo is muscle, cellular is cell, lipid is fat. This is fat in the muscle cell. It accumulates in the muscle cell. This is not theoretical. Here's what it looks like under the microscope. here is striated muscle in your arm or your leg, and all this black stuff. This is fat in the muscle cell. This is the intramyocellular lipid. Here it is under the electron microscope. This is fat in the muscle cell that does not belong there. It causes problems. It inhibits the enzymes that make this mechanism work. Insulin knocks on the door, but nobody answers. And as a result, the sugar piles up in the bloodstream because the insulin receptors are inhibited, their enzymes are inhibited from the inside here. And so you wind up with these high sugars, but the high sugar is not the problem. The problem is the fat accumulating in the muscle cell. And if the person happens to be overweight or obese, that adds another layer of problems. Here, there's getting to be a large literature substantiating intramyocellular lipids as the cause of insulin resistance. But if the person, as I said, has an obese abdomen, that's another layer of problems because that fat in the abdomen wrapped around the intestine is metabolically active. It puts out inflammatory cytokines like interleukin-1, interleukin-6, and they wind up causing inflammation throughout the body. It's known as metabolic inflammation. This is a real thing here. And one effect obesity is a state of inflammation, and one of the targets of the inflammation is these good old insulin receptors. Here they are. They're inhibited from the inner surface by the intramyocellular lipid that's accumulated in the cells. But here comes those inflammatory cytokines from the obese abdomen. They interfere with the insulin receptor action on the outside. So no wonder so many overweight people develop type 2 diabetes. Their insulin receptors are inhibited both on the inside and the outside. And so that explains what's going on with Dr. Sweeney's, the medical students eating that high-fat diet. It didn't take long, 48 hours of a high-fat diet, and their insulin receptors were all clogged up. However, they are clogged up reversibly, and that's the good news. If a person goes to a diet of whole plant foods, symbolized by the vegetables here, it's not all you eat, but now the good thing about the whole food plant-based diet that we're designed to eat is that good things happen in the cells, even with people with type 2 diabetes. What happens is all that fat now leaves the diet. The cell looks around for energy to burn and say, hey, we already have fat in the muscle cell. We can burn that for energy. And that's what happens. The intramyocellular lipid on a low-fat, whole food, plant-based diet, the intramyocellular lipid gets burned for energy. And as the obesity begins to melt away, those inflammatory cytokines decrease. And as a result, the insulin receptors open up. They're no longer inhibited by the fats and the cytokines, and they start working again. And that sure moves into the cells. And as a result, the hemoglobin A1C comes down. Here's a classic study comparing a whole food plant-based diet with the American Diabetes Association diet that allows some eggs and dairy. And the folks who followed the low-fat plant-based diet had a greater drop in their hemoglobin A1C. They lost more body weight. Their lipids improved more. Their kidneys started healing. They lost less protein in their urine. All the way around, the body heals. It's a reversible disease. I wish someone had told me that. And all of us who practice lifestyle medicine have patients like Jim, used to be 100 pounds overweight on 30 units of insulin, went on a whole food plant-based diet. A year later, he dropped the weight and he dropped his diabetes. He's off his insulin because he no longer has that disease. It's a reversible disease on a low-fat, whole food plant-based diet. Unfortunately, going back to our fictional vignette, the doctors don't mention this to the patient. They just put them on metformin, put them on Ozempic, put them on insulin, and do not get to the cause, which is actually the high-fat diet. Doctors who begin to use the healthy, low-fat, plant-based approach are forced joyfully to learn a skill, again, that no one taught us in medical school called deprescribing. Yeah, you got these patients on these potent drugs to lower their blood sugar. Well, as they lose weight and their insulin receptors open up, those blood sugars will drop to their boots. You not only can get them off their insulin and metformin, you have to get them off. And there's an art to doing this, and it's an easy one to learn. And most lifestyle doctors know how to deprescribe medicines for diabetes. Again, getting to be a growing medical literature substantiating the reversibility of type 2 diabetes. So that's the good news. This is what really should be covered. This is such a hopeful message. It should be shared with every patient and motivate them to adopt a truly healthy diet, one is low in fat and high in whole plant foods. So that's what Terry should have heard in the office from our doctor. I'll turn it back to Dr. Burns to continue the conversation.
Thanks, Dr. Klaper. So you can see how that's such powerful information, that diabetes is basically the cause and the cure are intimately related to what we eat, and that it's a reversible condition. And especially with someone with new onset type 2 diabetes, she's not so sick. You know, she's got some cardiometabolic abnormalities, she's overweight, but she's 47. She can absolutely turn this around. She doesn't have to continue getting sicker and having these band-aid solutions of chronic disease meds that aren't addressing the root cause. Her A1C was 7.5. I've seen people, if they decide to make lifestyle changes and they're supported adequately, they'll reverse that. Once you get below 6.5% off meds for 3 months, that's the remission criteria. And that's given by the American Diabetes Association, who does a lot of work with diabetes, doesn't necessarily want everyone curing their diabetes, but even they have remission criteria. And I think every patient deserves to know that in case they want to pursue that option. A lot of people do once they have the proper info on how to do it, and if they're supported along the way. But if we deprive them of that information, then it may be negligent. So I just want to paint the picture of what happens to Terry, right? What would likely happen to Terry, this patient from the encounter before, who is started on Ozempic for new onset type 2 diabetes. And by the way, we're assuming it's type 2 because of her other, her risk profile and age. It's usually appropriate to make that assumption. But if someone's younger, if they're lean, and it wouldn't make as much sense for them to have type 2 diabetes, you do have to check the antibodies to rule out type 1. Okay, so Terry started on Ozempic. First of all, the insurance company will take 1 or 2 weeks for prior authorization, right? If they do approve it. So in the meantime, she's probably going to be pretty anxious about the new diagnosis, especially without any real tools to address it. She's sort of instructed to limit carbs. She wasn't given any explanation as to which carbs are beneficial and which aren't. So what she's going to do is to eat more eggs for breakfast instead of cereal. And then she's going to have more chicken than pasta at the Italian restaurant where she works. Okay, so then she'll start Ozempic, and initially she'll have unpleasant but tolerable GI side effects. 4 weeks, she'll go up to the next dose and have a week of worse side effects, nausea, bloating, but those symptoms will abate. So then at the 6-week follow-up, remember the doctor promised follow-up in a month and a half, she will have lost 5 pounds, and together they'll make a decision to stay on Ozempic despite some intermittent queasiness. So then she's going to titrate up to the 1 milligram dose. And at that point, she feels like there's a ball stuck in her stomach. It's not leaving. This is a common side effect. It's because this is sort of the beginning of gastroparesis. So she calls the doctor's office, talks to the nurse. Nurse gets permission from the doctor to go back down to the 0.5 milligram dose. All right. Then it's the 3-month follow-up, and she's lost 14 pounds. A1C is just below 7 at 6.9, and her cholesterol's improved a bit, which seems to validate the current regimen. And we keep going. So 6 months, her weight loss has plateaued because she was only on a low dose. So she's not going to keep losing weight at that rate. Her BMI is 25 still, just on the cusp of overweight. Lipids are acceptable. A1C is 6.7 now. So meds are continued. So here's where things go awry. The parent company of her restaurant decides to restructure and lay people off. So she's without employment or health insurance, and Ozempic is way too expensive out of pocket. It's over $1,000 a month. So the doctor's office helps her find a compounding pharmacy. Okay, these are because there's a shortage of Ozempic and the like these days. It's actually FDA approved to have a compounding pharmacy do it sort of generically, sold at a fraction of the cost. So at this point, with the delay in her Ozempic, she's regained her weight. She's regained all of her initial weight, and so she's encouraged to. She wants to go back on Ozempic from the compounding pharmacy, and she does. Okay, and then inevitably, the manufacturer of Ozempic will make a sufficient quantity so that there won't be actually a dearth of it, and then the compounding pharmacies won't work. So I know this is convoluted, but this is the reality. I've seen it. Patients, they're started on GLP-1s like Ozempic. It seems to be a good move, but it's not a good long-term solution. Logistically, it's really hard to guarantee it's going to work because it's so expensive. If anything happens with insurance, you change states, you change your doctor, then you have this lapse in treatment and everything rapidly reverts back to your original status. Okay. Not to mention the side effects, short-term and long-term, the latter, which we don't really have a handle on. We don't have any long-term safety data. So probably makes sense to look at the root cause and see if we can take the lifestyle approach.
Yes, I totally agree with that. Like so many issues, and we touched upon this at the beginning here, how frequently the standard medical model really doesn't get to the root of the problem. We're great for making the numbers look better, whether it's blood sugar, cholesterol, whatever. But is the person's body really getting healthier? Are those arteries getting healthier? Is her inflammatory state truly getting healthier? And very often it's really not. It makes the doctor feel better, but the truth is, we see a lot of people, even though they're on statins, pounding down their cholesterol, they still go on to have heart attacks and strokes because the burgers and the buffalo wings that they can eat, because now their cholesterol is normal, are still injuring their arteries and still building up plaque that leads to the heart attacks and strokes. There's a false sense of healing going on here. Makes the numbers look better, but the tissues aren't getting healthier. And we got a similar situation here with the Ozempic there. You can force those numbers down. But as Dr. Burns said, it's a temporary, it's almost a physiologic parlor trick to force that weight off. But it's just being held down there by this drug. And as soon as you take the chemical brakes off with the drug, things revert back to normal. The weight comes back, the diabetes comes back. You're not really helping this patient heal. What would help this patient heal is an honest explanation of the pathophysiology involved and referral to a plant-based dietitian and maybe a health coach for a few weeks to help her really realign her eating habits. And then you'd see this person losing weight for good reasons because she's keeping her tummy full of high fiber, high water content fruits and vegetables. And that weight would come off naturally, and the diabetes would fade in the rearview mirror. And while we're talking about dietary lapses, at least in dietary counseling, I need to touch on the evil twin of this, which is I've had patients report that their doctor is a big fan of the paleo approach and the keto approach and put them on a bunch of high fat, low carbohydrate foods, a bunch of oils and eggs and meat. And lo and behold, their sugars went down. And they said, see, that's the real thing you need to do is get on a low carb, high fat diet, and boy, those numbers are going to get better. Yes, they will. But let's look at really what's going on. The issue is this. As I mentioned, the high-fat diet clogs up the insulin receptors. So will the paleo diet and the keto high-fat diet clog up the insulin receptors? You bet they will. But their blood sugars stay normal because they're not eating any sugar. They avoid those carbs. And so there's no starches, no grains, no fruits, etc. And you do that, your blood sugar is going to stay low. You're still highly insulin resistant. And that's the issue. If they do eat any carbohydrates, they do have sweet potato or some whole grain bread. Well, their insulin receptors are all clogged up, and so that sugar spikes their blood sugar levels after eating all that fat. A little bit of sugar will raise the blood sugar levels, and to which the paleo pushers and the keto docs say, see, those carbs are evil. I told you they're going to spike your blood sugar. Well, yeah, but it's a physiologic parlor trick. You've jammed up the insulin receptors and gave them a little glucose challenge, and of course it goes up. But this is not normal physiology. Our Paleolithic ancestors didn't eat fat 3 times a day. We are carbohydrate burning creatures meant to burn whole plant foods. And so not to be seduced by these artificially low numbers on the keto diet because we're not eating any sugars. But that's again, puts us in a state of ketosis, which is fine for a few days. But boy, you don't want to stay in ketosis week after week after week. That's a stressful state of acidosis in the body there. So anyway, just wanted to deal with the person who said, I heard the paleo diet lowers blood sugar. It does, but for some very unphysiologic reasons there. So anyway, Terry doesn't need Ozempic. She needs salad and vegetable soups and steamed greens and bean chilies and a healthy whole food plant-based diet and a good walk every day. That's really the best curative program for someone like Terry.
So one of the things that I would love for us as a profession to talk more explicitly about in the exam room is the difference between complex and refined carbs. A lot of people don't understand that. I almost never hear that being differentiated. And so carbs are generally demonized as a group, a blanket statement. And I would agree, let's skip the frosted flakes and donuts. But that's a completely different physiologic experience from complex carbs. So farro, quinoa, oats, teff, barley, these whole grains have a completely different effect on the body. Can you speak to that, Dr. Klaper?
Well, sure. Again, the key is these are whole grains, like Mother Nature made them. And when Mother Nature makes any plant, they're mostly 90+% fiber, non-absorbable carbohydrates. That really is what lettuce and spinach and whole grain barley and rice really are, mostly fiber and water in there. And the carbohydrates, the sugars that are in there, again, they're firmly bound to they're trapped part of the fiber matrix. So when you chew up that mouthful of barley and swallow it down, it takes hours for your digestive enzymes, well, not hours, but a good hour or more for your digestive enzymes to work their way into that piece of barley, and for the amylase enzymes to start digesting the sugar molecules, and then they have to be absorbed. And as a result, the blood sugar after eating whole grains or salad or vegetable soup goes up very gently. It shouldn't really spike like it will from the frosted flakes there. And then a gentle rise in blood sugar from whole plant foods produces very modest response of insulin by the pancreas. And the sugar comes back down. And this is what normal digestion and physiology should consist of. as Dr. Burns said, once the hand and mind of man gets involved here and starts extracting those sugars and making pseudo foods, making donuts and vegan cupcakes and candy bars out of it, oh, that sugar leaks into the bloodstream, and you get a big insulin response. And fat stores and all sorts of things. But that's not what we are designed to run on. Whole plant foods in their natural state that you could recognize them if they were growing in the garden. Oh, there's a cucumber there, there's green beans over there. That's what should be on your plate in the forms of stews and soups and chilies and salads and steamed veggies and celery stalks dipped into hummus there. But again, whole plant foods is the natural fuel for us two-legged hominids here, and it'll be a gentle one with your pancreas. And get your fats out of whole plant foods, out of avocados and walnuts and flax seeds, not out of glass bottles, and not out of egg yolks, et cetera, there. So again, you don't want to put diesel fuel in a gasoline burning engine. You don't want to put a whole bunch of fats into our carbohydrate burning metabolic mechanisms that we have in our body there. So whole plant foods. I'm gonna get a T-shirt that says "Eat plants and get on with it." You know, that's ultimately what it comes down to. And so that's what Terry should have heard in the office from her doctor.
So there's this fascinating piece of physiology that I think I've learned within the last year, and I tell my patients. So when you know how the gut microbiome is, everyone's talking about it. When you eat a whole food plant-based diet, those are prebiotic foods. They're different fibers that go down, and in order to be digested, they spawn beneficial microbes, bacteria, to digest them for us symbiotically. Okay, so then you have a healthy inner rainforest. And then what you do as a byproduct of that digestion, you have these short chain fatty acids like butyrate. So you might have heard others on the channel talking about butyrate. That's a really powerful molecule. It's anti-inflammatory. It has all these effects. One of them is to promote our endogenous or our own GLP-1. So we have glucagon-like peptide. That's the only reason we have receptors. That's why Ozempic works, is because we have natural receptors for that compound. We have our own natural Ozempic, right? And you can optimize it by having everything else working in order, right? And some of that is having a healthy gut microbiome. So I just find that really compelling. I try to tell my patients, we have our own Ozempic. Let's just harness it so that it's actually effective. Because people who have gotten off track and might be recommended Ozempic, their natural faculties, they're not optimized anymore. Things have gone awry. They're starting to decompensate metabolically. So how do we get back into metabolic health? It's basically like we're never going to be wiser than Mother Nature, right? So you just try to harness this natural the natural physiology.
Yes, you get these repeated validations of what we've been saying here, because a diet of whole plant foods, and again, it's soups and salads and chilies and curries and whole grains and etc. There's mostly fiber and water on your plate when you're eating that. And what does it do in your stomach? It takes up volume. It stretches the walls of the stomach and the small intestine. Well, that's what makes you release your own GLP-1, as Dr. Burns just saying. We've got our own there, and look how beautifully a whole food plant-based diet stimulates that. And because these whole plant foods are mostly fiber and water, it becomes guilt-free eating. If you want to go back for a second or a third bowl of vegetable soup, who cares? It's vegetable soup. It doesn't stick to you. You pee out the water and you poop out the fiber, and we go there. And so the validations that nature is giving us are all around, flashing brightly here. And this whole diabetes issue, the type 2 diabetes, is such a self-inflicted metabolic dysfunction that we create from high-fat diets, like putting sugar in the gasoline tank there. It's going to gum up your spark plugs and your and the gas line and the catalytic converter. And that's what all that fat in the diet does. And again, we need fats. Fats are not, in their natural form, they're not the enemy. But again, get it out of a handful of walnuts, a slice of avocado on your salad there, some flax seeds sprinkled on your cereal. That's where to get your fats, not out of processed foods or glass bottles there. So honor our anatomy and our physiology, and the diabetes fades in the rearview mirror there.
So one more word on fat. So in addition to contributing to intramyocellular lipids, like you saw in Dr. Klaper's slide, which is the beginning of insulin resistance. Okay, so imagine that it's like these muscle and liver cells are clogged with fat, and the insulin that wants to interact with the cell can't do it. The cell is clogged. It's out of order. Okay, in addition to that piece, in a given meal, when you eat fat, it makes your insulin resistance worse. Okay, so there was a study from March 2024 recently with in Washington D.C., and they studied type 1 diabetes, type 1, right? So that's the autoimmune version, more often diagnosed in youth. The body's own antibodies are attacking those beta cells in the pancreas that make insulin. And diet hasn't been so well studied in type 1. There's many, many more type 2 patients. And so this was a really interesting study. They randomized one group to a whole food plant-based and the other group to a portion controlled diet. So they actually looked at their metabolic parameters, and they decreased their calorie intake per day. So they were calorie restricted, but not fully plant-based. Okay. Long story short, the plant-based group ate 111 additional more grams of carbs per day than the portion controlled group. They ate over 100 grams more carbs every day, and yet their insulin requirement dropped by 12 units of insulin per day. So remember, type 1s, they're always going to need some insulin, but there's so much room for them to decrease their requirement, to need less insulin per day, because their insulin sensitivity is optimized. Okay, so while their pancreas isn't making it, what they're administering to themselves through the needle is working better because of their diet. So there's so much room for that, because with the modern diet, type 1s, it's like they're getting inundated with both, really. They have the autoimmune issue, and then it's just getting worse. Everything's been exacerbated by the standard diet and insulin resistance. I just found that amazing. You can eat significantly more carbs, reduce your insulin requirement. And of course, that's part of the same physiology. That piece of it applies to type 2. So.
Indeed, and I would encourage people, if you are carrying extra weight, really jump on the advice train that Chef AJ has given you. She's been so successful in losing weight here. And you don't want to keep your blood full of fat, which happens. And again, I'm not fat shaming anyone, just explaining the physiology. If you've got an obese abdomen, that fat is constantly being released, is called spillover. There's fat in the bloodstream pretty much all the time from the abdominal fat stores. And of course, the person might be eating lots of fat. The problem with that is that fat starts depositing in the body, including in the pancreas. And the fat becomes toxic to the beta cells that produce insulin. It's called lipotoxicity. And as the months and years go by, the pancreas starts getting damaged. So similar to the type 1 diabetes folks who've lost their beta cells and just can't produce insulin, the type 2 folks who have insulin resistance in their cells, that's not the only problem. As the years go by, they too lose pancreas function from lipotoxicity. So there's a lot of social support these days where you can be healthy at any weight, etc. I'm highly skeptical of that, and certainly if you've got diabetes, I would really urge you to be kind to your pancreas and let that fat melt away again by keeping your belly full of rice and beans and greens and fruits and vegetables and low fat, high carbohydrate, high fiber plant foods. Your pancreas will last a whole lot longer if you do that. So don't be complacent that carrying lots of extra body fat is a healthy thing. I really don't believe it is.
One more factoid, and then I'd love to see if Chef AJ has any questions, or yourself or from the audience. But the factoid that I think is really compelling is that the body naturally, a healthy lean body, will use about 30 units of insulin a day. Could be up to 50. It's like 20 to 50. Okay. I've had patients with type 2 diabetes who need insulin using up to 300 units of insulin per day. It's really scary. I worry for them. When you need that much insulin, there's research that demonstrates there's a really a cardiac strain. So their cardiometabolic risk is so much higher just by needing that amount of insulin. So the point is that our bodies are just like magnificent. So if we can, they're so efficient. If we only need around 30 units a day normally, and some people are needing 100, 200 more, we can see how things have gotten off track. And I'm really hopeful, actually, because when patients are given this information and given the support, they're really receptive. They're really interested in working with us to make these changes, because they would love to not need all that insulin, or to not start the next drug, or to feel better, not have the peripheral neuropathy or the retinopathy getting worse. So I think overall, I want this to be a hopeful message. Chef AJ, any questions over there?
Yes. Okay. So I'm looking through the chat, but there were questions that were submitted in advance. If you don't mind answering them, the thing is we don't know for sure if they're always on diabetes because we don't always know the topic. So if you can answer them, the first one, help. It's from Deborah. Cardiac stents, pros and cons. My husband has had bypass surgery and 2 stents in the past. He has not been feeling healthy for a few months now, difficulty walking short distances without getting totally wiped out. The surgeon advised a stent last October and husband said no, but now he is relenting as it is impacting his quality of life. He follows a whole food plant-based low SOS about 80% of the time. That's a wild estimate at home. It's 100% not always clear what he eats outside the home. Debbie would appreciate your help with this matter.
Oh my. I'll say your body is never not looking. Your arteries, and especially this man, his arteries are never not looking. And that 80%, nice, but that whatever's in that 20% is really hurting his arteries, and his disease is progressing. And whether he needs a stent depends on the microanatomy of his particular coronary arteries, and whether he's having angina when he walks, and that's up to the cardiologist and the patient to decide. But there's no question this man is cruising, is marching towards a catastrophe, a heart attack or a stroke or whatever. He needs to get on Dr. Esselstyn's heart disease reversal program, boots in, as they say in New Zealand. He needs to be fully committed. He takes those arteries everywhere, including to the restaurants when he's on his own there. So to thine own arteries be true, Shakespeare said. If he didn't, he should have said it. Dr. Klaper certainly said it. So that's what this man needs. And he's run out of cheating room there. He's just cheating himself at this point. So again, get on Dr. Esselstyn's program, and he can hopefully even avoid another stent. Dr. Burns?
I'll leave it there.
Okay, fair enough.
Yeah.
What is it you say, Dr. Klaper? Welcome to camp. Stop kidding yourself.
Well said. Thank you, AJ. Exactly. He needs to stop kidding himself. 80% is not good enough.
Thank you. And this is from
Yes,
Melissa.
I'm sorry. I have another teaching commitment.
Yes, you do. So thank you, Dr. Klaper, so much. Maybe Dr. Burns can stay around for a couple more questions.
Great.
Bye.
Thank you, everybody.
Thanks,
Wishing you
Dr.
all the
Klaper.
best and
Take
keep
care.
eating plants. Okay. Bye-bye.
Thanks, Doc.
Okay, so you want to breeze through these on your own, Doc?
Let's see.
All right. So Melissa says, I have lipoprotein little a and recently had a CT cardiac calcium scoring at the recommendation of my doctor due to having inherited lipo little a. My score was 1 and my provider wants me to take a statin. My overall cholesterol is 170. I'm mostly whole food plant-based, no animal products, and am eliminating processed foods. Is it true that statins can raise lipo little a? Can you expand on this condition and what cholesterol numbers I should strive for?
This is good stuff. The caveat is that we can't really answer individual questions because I would need so much more information. I know that was plenty, but I would ask like 500 more questions. It's my style. What I could say is that sometimes when people are on the fence about starting a statin and they have some data points that show an increased cardiac risk and some data points that are more reassuring, what they then do, that you can do a couple more things. So you can get a panel of the really specific, basically inflammatory labs that look at the vasculature. So you can get a panel, it's like myeloperoxidase and different compounds like this. It's a panel. You can do it through the Cleveland Heart Lab, or you can really, any lab company where you can kind of order your own, or do that through your physician. You'll find this panel. We could probably make a link to some of this information. But what it does is it's a surrogate for the inflammation that's happening on the inside of your blood vessels, for instance, your coronary arteries, which is really what counts. Because when we look at our LDL and these different things, they're more like supporting evidence for vascular inflammation and atherosclerosis, but it's not definitive. So we want to see what exactly is in there. If we could do an angiogram on everyone, but it would be too high risk. So we do these labs instead. Work with your doctor. You really have to understand the risk. There are some people who should be on a statin. I'm not universally opposed to statins. I think statins for primary prevention, which is when you haven't had heart disease ever before and you're starting a statin then, I think that's way overutilized. Every few years, they keep coming out with these meta-analyses. And they say, whoops, actually, there isn't as much evidence for statins as primary prevention as we thought. It keeps happening every few years. So I'm not as inclined to start them when somebody in front of me has never had heart disease before, like known heart disease, like they had a heart attack, they had a stroke, they have a really intense family history, they had an incidental finding of calcifications on a CT of their chest. Those people I'm more pointed toward treating. But in the absence of those risk factors, and if you know the big picture, then I'm less inclined to start a statin.
Thank you. This question is from Julie Ann, and she said, is there any truth to earthing or grounding the information that's been brought to light lately? I watched the YouTube video and it was called Earthing, and it makes sense, but would love to hear what one of the doctors think.
Unfortunately, I'm not familiar with it. Maybe I'll have to watch Earthing.
Yeah. Maybe it's walking on the ground barefoot. I don't know what it is either. So yeah, I wonder if Dr. Klaper would have known. I don't know what that is. So let's try again. Okay, here is, oh, this one's really, really long. It's too bad. They can't, you guys don't do private consultations, right?
I don't. Dr. Klaper, with his new role up at Aroga, he may be taking private patients. So we can explore that.
Great, thanks. Let's see if there's one that I can it doesn't have like they just give I appreciate all the medical history, but it would be like a whole show just to read some of these. So you know,
Yeah.
okay. All right. Well, this one's not too long from Roseanne. Have you heard of enhanced breast cancer detection? I recently got a mammogram and was offered this in addition for a cost of $40. I was told it was an AI program that is more accurate reading of a mammogram. Any thoughts?
Interesting. I'm not too familiar with that. I know that AI is rapidly being sort of incorporated into radiology because it could take a picture, it can basically collate like a million photos online from its language model and really assess like better than any human eye could. So I know that's on the way. I don't know if we have good data for its utility in detecting a lesion on the mammogram yet, but I'm also not a breast specialist.
Thank you. And we haven't had one on lately. So maybe Dr. Christy Funk would be someone who would know that. This is from Anonymous. How do you treat bloating on a whole food plant-based diet? Do you think that SIBO breath testing is accurate or even necessary?
Okay, interesting one. So bloating can be common, especially when people start to eat tons of produce or legumes. There are a few tricks of the trade. One is remembering the physiology. Always think about the physiology. When you start to incorporate new foods, you need bacteria in the gut to digest them, like we were talking about earlier. So they're not going to magically spawn immediately. So you try to titrate up your dose of healthy food. If you're someone who really was not doing beans, lentils, or chickpeas much at all, there are a few tricks. First, go gradually. Start with a thimble size, a few of them. Then go to a spoonful, then a quarter cup, a half cup, until you've built the microbes to break them down. What it is some of the carbohydrates in those legumes are more difficult to digest, but you can help your body do it. Another trick is to cook them really well, so they shouldn't be tough at all. I like the smash test where you just put one on the cutting board, right? You've been boiling the beans. You take one out, put it on the cutting board, and then you just plop a utensil on it. You shouldn't have to push down, and the bean should smush. Okay, then it's tender enough to be ready, and that's going to help with digestion. Another point on beans. Another one is if you're not doing pressure cooker and you're cooking on the stove, first of all, soak them really well if you're cooking from dry. And then they're cooking on the stove. Okay, so you know that foam that surfaces on the surface. So what you can do is skim it off because some of that foam contains some of those carbohydrates that are difficult to digest. Those are legume tricks. If you really have a sensitivity, you've done all these things and it's not working, you could be sensitive to certain food groups. And if it's really terrible and debilitating, then you may have to pursue an elimination diet, right? Which you probably do with the provider's experience with that. But it's essentially the concept is to knock stuff out of the diet and then really gradually incorporate it back in a methodical way so you can identify if there are any offenders that are bothering your innards. Okay, SIBO. So small intestinal bowel overload. I think that's what SIBO.
Bacteria. I think overgrowth. I think it's bacterial overgrowth. Yeah.
I appreciate the reminder. So the concept is that you're having it's like your gut flora, but it's in your small intestine where it shouldn't be, and it's overgrown, and it's a disadvantageous species, and so it can cause bloating and unpleasant symptoms. I think it's a really important diagnosis to keep on the differential. It's less common, but it's probably more common than is diagnosed. So we don't want to miss it. If someone's really having a lot of bloating and you don't think it's infectious, right? Maybe by now you've done stool testing and there are no parasites and there's no, no infection, and it's not H. pylori, you've ruled that out, then it may be time to get a SIBO breath test. So talk with your doctor and see if that's the right move.
Thank you. I'm going to shorten this question so that you can answer it. It's about, let's see, who's it from? Okay, so it doesn't say who it's from. It's a condition called neutropenia, and they're saying body lower than normal neutrophils. So any advice on that? They're wondering if it could be a nutritional deficiency. The absolute neutrophil count is 1,394, white blood cell count 2.8.
Okay, so neutrophils are one of the white blood cells. Okay, you have the red blood cells, the white blood cells. Then the white blood cells have a few different types. Neutrophils are one type, and if it's low, it's neutropenia, just for some background. Neutropenia, when it's mild, can be benign and nothing necessarily to worry about, but it should be worked up, because there are some causes of neutropenia that are serious, like an infection or neoplasm. Okay, so what we want to, you really need to have that worked up. There have to be follow-up labs, and if appropriate, imaging, to try to understand where the neutropenia is coming from. Some people, because remember, these cells are made in the bone marrow. So some people, if it's really unclear, they might need a bone marrow biopsy. The problem with neutropenia, if it gets too low, then you're immunocompromised. So you're susceptible to infections, and it can be a serious situation. So that's one you definitely need to get worked up.
Thank you. And then the last question that was pre-submitted from Pat. Pat had cataract surgery in August of 2023 and now has under eye bags, never had any lines or face, just puffy under eye bags. Eyes feel tired, use drops, ice packs, takes antihistamines, hydrate water, elevate bed. Any suggestions? I was young, in my 50s, to have cataract surgery. I have no wrinkles, just bags under both eyes. This is from Tish, actually. I don't know why I said Pat. Thank you.
Yeah, that can be distressing. If they're really obvious, everyone looks at our face. I've never personally heard of them resulting from cataract surgery, but could be. Remember that under the eyes, the skin is thinner. So when we have any sort of inflammation or fluid accumulation, it shows up under the eyes. So that's why in the morning, right, you might have bags under the eyes because you've been horizontal and fluid's accumulating there. I'm not a cosmetologist. There's so many people who are really like advanced methods for smoothing out the bags under the eyes. From a cosmetic perspective, I don't really know, but there's going to be a lot of content out there.
Thank you. Here's a question I just saw in the chat from when you were talking about diabetes. And the question is, what is your approach when it comes to help a pre-diabetic teenager that has no family history of diabetes?
Pre-diabetic teenager with no family history of diabetes. And what's the general approach? Is that the question?
Yeah, that's what it sounds like to me. Yep.
Okay. Yeah, thanks for that. This is a very common situation. Pre-diabetes basically means that you're on track physiologically to someday get diabetes. Now, it's just like climate change. It doesn't have to happen if we change course, right? So that person just has a particular need more than everyone else to be super healthy. So the same information that we devoted this hour to applies to prediabetes, because prediabetes is the beginning of insulin resistance. Actually, prediabetics have so much success with this because they're not so deep in the situation. Like their insulin resistance is mild, so it's readily reversible. And this is exactly when people should start working with a dietitian who's hip to whole food plant-based. There's the diabetes prevention program, which is government funded, massive program that showed in the 90s, it showed that prediabetes could be reversed very easily with like a comprehensive lifestyle approach, better than drugs could do that work. Okay, so if I had someone with prediabetes, I would make sure that they weren't overwhelmed and freaked out about it, but I would compassionately explain that it's a serious situation and we have to get on track promptly. And I would want to meet with them soon, like follow up. So I would just encourage that the family to take it seriously and make sure that person is well supported to get that A1C back down under 5.7. At that point, you don't have prediabetes.
Thank you. Last question in the chat from Rachel. Could you explain how gestational diabetes works? How does it come about? I had a friend who had it with 2 pregnancies, and now she's afraid of any carbs, and she's 51.
Gestational diabetes, yeah, there's so many types of diabetes. The common thread is that you have hyperglycemia, okay? There's too much sugar in the blood, and that has an effect on the organs over time. That's why we take diabetes seriously, whichever kind it is. In pregnancy, when you have hyperglycemia, what happens is the little fetal pancreas puts out more insulin to deal with it. And the insulin from mom also crosses over. And so you have the fetus, the growing fetus, exposed to more insulin, which promotes growth. You want some growth, obviously, for a fetus, but excess growth makes the fetus too big, macrosomia, big body, basically. Well, that's dangerous because you could get stuck in a vaginal delivery. You could have a shoulder dystocia, and you might have to schedule a C-section. It's not the end of the world, but there's still risks. And the scariest thing is that fetus with macrosomia, the baby of someone with gestational diabetes, is a higher risk of developing diabetes and obesity in adulthood. So it's something that you really want to tackle. While there's a massive role for lifestyle in preventing and treating gestational diabetes, there does seem to be more of a genetic component there. So you can have really fit, lean mothers who develop it seemingly randomly, gestational diabetes. And so even if that's the case, there's so much we can do with lifestyle to mitigate that, basically to control the hyperglycemia during pregnancy, protect the fetus, protect mom, and then continue those healthy interventions after delivery, because mom at that point has an increased risk of developing regular type 2 diabetes in the future when she's had. But the nutrition intervention is not to limit carbs. Okay, it's to limit junky carbs like Rice Krispie treats and soda. But there's absolutely no nutritional reason to limit complex carbs like oatmeal and brown rice and sweet potatoes and these things. What you want to do is, like we were saying before, the same nutritional advice applies. You want to reduce the fatty and high protein foods, which worsen your insulin resistance and promote the secretion of extra insulin. That's what protein does. People don't always know that, but protein, like especially whey protein in milk, drink a glass of milk and the pancreas responds by secreting insulin, just like it would secrete insulin if you had a chocolate chip cookie. Okay, so you get all that extra insulin, then the body gets off track. It worsens the insulin resistance. So putting it all together, there are more genetic propensities for gestational diabetes. So you can have really fit people who develop it. Even then, it's amenable to whole food plant-based nutrition. You just want to make sure you're working with your OB to take any necessary supplements to get the fetus their adequate nutrients, right? So put a balanced and thoughtful whole food plant-based diet in pregnancy is totally doable and recommended if you have the information and support. And there are great books on this. There's like Nourish by Reshma Shah and Brenda Davis about raising a plant-based family. There's For Fork's Sake by Rachel Brown, which also emphasizes how to do this in the family. So just some things to think about. Thanks for the question.
Great. Well, Dr. Burns, you did great all by yourself.
Well, thanks for the questions.
Yeah. Are you practicing anywhere right now, or are you still in your residency?
No, I finished residency. I have a couple of months of summer and I'm working with Dr. Klaper's nonprofit part-time. I'll continue doing that ongoing, but I start my clinical work in Rochester, New York in September.
Are you going to be working with Dr. Ted Barnett by any chance?
Not directly, but I'd love to hang out with him and the team over there.
I got some emails. His 70th birthday today.
Is it today?
That's
All
what
right.
the email said. I just met him in Cuca. He's great. Well, thanks so much, Dr. Burns.
Thank you. Always a pleasure.
Absolutely. And thanks all of you for watching another episode of Chef AJ and Friends. Please come back next Wednesday, July 31st at 10 a.m. when we will be discussing the brand new book of Dr. Frank Sabatino. Have a great weekend, everyone. Thanks for watching. Bye-bye.